Welcome to the Interventional Glaucoma podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Welcome everyone to the latest episode of the Interventional Glaucoma podcast. My name's Gus Gazzard, Director of Surgery at Moorfields and Professor of Glaucoma Studies at UCL in London. It gives me great pleasure to be able to introduce to you two speakers to help us work our way through the developments and the minefield of the technical aspects of what lasers are, and particularly what excimer lasers are when we're using them in the eye with an Elios ELT. I've got Neeru Vallabh from the University of Liverpool, Senior Lecturer and Specialist in Multiomics, as well as a clinician and glaucoma specialist.
Thank you so much for inviting me today.
Welcome. And Dirk Mühlhoff from Munich, who is one of the world's experts in all things laser and specifically all things eczema. What he doesn't know about lasers, I don't know, but we're going to hear from him some of the real details and hopefully an explanation that will be simplified enough for us mere glaucoma specialists about what an eczema is, how an eczema works, and why it's appropriate for targeted, specific tissue ablation intraocularly at the trabecular meshwork.
Thank you for having me. I'll try my best.
Very welcome. So to start off, we've had a number of lasers available to us in ophthalmology for decades. Neeru, what do you think makes it so appealing for ophthalmologists that we use lasers for treating so many different eye conditions?
Yeah, thanks, Gus. It's so funny getting this question from someone like yourself who's considered a laser guru in the field. But when we think about lasers, what's really appealing is that it's a combination of precision, safety, and efficiency. So we know the eye itself is so suited to laser itself because of the fact that it's optically accessible. So we can actually then focus this energy on very microscopic structures like the trabecular meshwork, which is only 350 micrometers in height. And then from a patient perspective, lasers are typically quick, they're well tolerated, they're repeatable. And then from a service perspective, there's the ability to sometimes take the lasers away from theatre and do them in an outpatient setting, like the likes of SLT.
Cool.
And then there's constant innovation in the space. So we've seen, obviously, even with the Elios, for example, we see constant change and improvement in the types of lasers that we have available to us.
I love lasers as an example of the way in which technological advance has led medicine by the hand, and what we're able to do now was only dreamt of or not even dreamt of 20 or 30 years ago, but it's the technology that's made things available, and then the real innovation of industry and physicists and clinicians working together to work out what new things we might be able to do with new technology. So Dirk, to help guide us through that technology, would you like to give us a brief introduction of the classifications and types of different lasers and their effects on tissue?
Sure. So when it comes to the therapeutic use of lasers in ophthalmology, I think it's important to recognize that there are three different distinct mechanisms of action. And each mechanism of action is based on a different physical effect and uses different types of lasers with different properties and has very specific areas of application. So bear with me, I try to make it brief, but let's go through one by one very briefly.
It's a lot of physics to get through, but let's do our best.
So first to talk about is coagulation. Physically, the effect is heating of the tissue through what we call linear absorption of laser radiation. Typically, those lasers work in the visible wavelength range. Typically, they have very long laser pulses and, relatively speaking, large beam diameters, still less than a millimeter, but relatively large as compared to the other lasers I'm going to talk about. Laser technology-wise, you know them as diode pump solid state lasers or diode lasers, and the broadest application example for this is retinal coagulation. The effect here is very different from the other lasers. The second mechanism of action that many people know is photodisruption. What happens here physically is that tissue is torn apart through a shock wave initiated by a laser pulse. Typically, those lasers, they are at the infrared end of the spectrum. They typically use very short pulses, even sometimes ultra short pulses, in the range of nanoseconds or femtoseconds. And to create this effect, they need to be very sharply focused on a micrometer scale. Laser types used, everybody knows medium yak laser or fiber lasers. The broadest application is PCO, but also femtosecond lasers in the refractive surgery space fall into that category. Now, ELT is yet different from those, as it is based on the third mechanism of action, which is ablation. Ablation is, again, very different because this is based on the complete disintegration of the tissue by breaking the chemical bonds through UV radiation. So the laser has an emission wavelength in the UV range. It also uses very short pulses in the nanosecond range and is able to work with more or less larger beam diameters in the sub-millimeter range. This is where excimer lasers come to play. And the two applications that many people know are LASIK on one hand, but also ELT on the other hand.
So I like to think of these categories or these lasers as burning lasers, exploding lasers, and evaporating lasers. Is that fair, or is that a bit simplistic?
I would say that's probably a little dramatic to coin it that way. And in particular, I heard the term burning, and I think that is really an inappropriate term for excimer lasers because it suggests that this would include or involve a lot of heating. Just the opposite is the case. The absorption of ultraviolet radiations happens in a very shallow area on the surface of the tissue, and through the short pulse, this disintegration that I explained happens so rapidly that the products of this reaction are carried away before even the thermal load can be transported into the surrounding tissue. And that's very important because this is why this is typically called the so-called cold ablation. So burning is really not the appropriate term for this mechanism.
So this non-thermal cold ablation, is it that means there's so little collateral damage?
That's exactly the reason why that has been clinically observed, but Neeru can much better talk about that.
Yeah, so we've done experiments on human donor eyes where we took segments of the anterior segment and we used the Elios to create some microchannels. This was together with Carl Sheridan in the University of Liverpool and Lucy Bosworth, two of my great colleagues. And we did X-ray CT imaging of the trabecular meshwork. We really wanted to visualize the pores that were created, and we were quite amazed to see how well defined these pores were, and that it led to an opening into the Schlemm's canal space. So this appeared to have a preserved structural pore, which created a nice neat opening into the Schlemm's canal. And we're now interested in looking at some of the biological changes that may be happening around these pores, which we'll hope to discuss in due course.
And is that something you're doing in an animal model?
No, with human donor eyes.
So human donor eyes sufficiently recently obtained that you're able to look at biological responses?
Yes, but that's what we're focusing on at the moment.
Okay, so Neeru, so what I'm hearing from you is that we get very discrete, sharp-edged, for want of a better word, channels in the trabecular meshwork. And I've seen some of those beautiful videos, and we may even be able to put a link to that with the podcast, I'm not sure. But some of those amazing videos of that X-ray CT histology, which I think blows everybody's minds when they realise that it's a real tissue image that's generated that, and it's not simply a model or a computer model. Do we think that those holes remain there as they are long term? Is it something that risks closing up? Because I've looked at eyes that have had an Elios laser months later and seen photographs of those years later, and there's still an opening there.
Yeah, so that's what I was thinking of, is that there are images that have shown that those pores remain for 8 years. And in my experience with patients that we have, when I'm looking at them, we're running into probably 2 years post-procedure now, you can see that those pores are defined. So I think by the nature, perhaps the way that the laser works, which obviously Dirk may be able to advise, but I think those pores do remain as far as I'm aware.
I know, so that successfully bypasses the outflow resistance that we know occurs in the trabecular meshwork, at the trabecular meshwork, blocking the flow of aqueous out from the anterior chamber. So you're effectively restoring a natural outflow through the remaining channels that are left untouched by the Excimer laser.
Yeah, and that's what I think we found quite impressive when we were looking at the X-ray CT images. Although the pore has been created, you don't see like a surrounding contraction of those fibers from the pore.
Because of the lack of coagulative change and damage to the proteins.
Yes, that's what I would assume.
Got it.
But obviously that needs to be studied further, and we hope to potentially give further results in that regard.
Dirk, can I ask you a couple of questions? I mean, they're slightly sort of simplistic questions, but a lot of people, when I've used the Elios in theatre, are worried about safety and depth of penetration. I know that some surgical colleagues even have worried about going too deep with the laser, or they've worried about side effects. And then some of my nursing colleagues have been very worried about the word laser and the safety of having a probe in the operator. Can you explain the physics that lie around the safety aspect of that? Because is it right that we don't need goggles with this laser?
That's correct.
I'm glad to hear that, because I've never worn goggles with this laser. So that's a relief, particularly since we seem to be recording this. So how does that work in terms of the physics of that? Why is it that the laser doesn't bounce around the room, taking our heads off?
So first of all, the laser is applied through a fiber probe. The radiation only exits at the end of the fiber probe, and the fiber probe touches the tissue. There's kind of no way for the radiation to escape. But even when propagating, when the beam propagates, you have to understand that almost all materials are very absorptive to UV radiation, which means even a very shallow layer of material fully absorbs UV radiation, including water. So the eye kind of has a natural shield. The tear film itself absorbs this type of radiation.
So if I fire the laser in the anterior chamber by mistake, it doesn't go anywhere because the water just catches it and absorbs it. Is that right?
That's right.
I think that's as I understood it. But it's very good to hear from a proper physicist that there's the reasons behind that. So does that mean that you need to have a certain amount of physical contact between the end of the probe and for the propagation that you described, the laser leaving the probe, a certain amount of contact with the target tissue of interest, the trabecular meshwork?
Yeah. This is why fiber is used inside the eye and really being brought to the trabecular meshwork and not acting from remote.
Understood. So how big are these channels that we're making? I mean, you've done some microscopy, and I understand that I think your company is actually producing the lasers. Is that right? So how big is the probe, and how big are the holes?
They're exactly the same size. That's part of the physical principle. So the fiber probe has a diameter of 200 microns, and that's the diameter of the channel that is great.
And the duration of the pulse, with a little pressure to ensure contact, is determining how deeply it goes in, because it's a short pulse that is delivered.
So in terms of the effect that the laser creates, there are a few parameters that really determine the physical impact. One is the number of pulses, and then there is the energy per pulse. The Elios laser is designed such that each microchannel is created through a sequence of 20 pulses. Each pulse having a pulse energy of 1.3 millijoule, and this creates these microchannels which are roughly 80 microns deep. And in one setting, 10 of those microchannels are created.
So we've got 10 of these channels. Neeru, you've used this laser a lot in eyes, in people, in patients. What's been your experience around getting that channel and the success of getting a patent channel? And somehow, how do you know that you've got a patent channel?
Yeah, so I tend to do mine at the end of the case. So usually I look for that reflux of blood into the Schlemm's canal. But the benefit is that with the probe itself, it has a 25-degree bevel tip, which helps to ensure that you have contact with the trabecular meshwork. So when I'm actually doing the procedure, I'm looking for bubbles that are created, which are as a result of the laser and are a promising sign. And sometimes actually reflux of blood. Because the Schlemm's canal is now full of blood, you know that you're through the trabecular meshwork and into that space. So that's reassuring signs during the operation that I feel like they're correctly located and the laser's having an effect and there's correct contact with the trabecular meshwork.
And what are the clinical effects, the clinical outcomes been for the patients in terms of, I don't know, pressure reduction or effects on medication need?
Yeah, so looking at our results for 12 months, we've reviewed some of our cases and we're getting sort of a mean pressure of around 50 millimeters of mercury and reduction of 1 to 2 medications. But at the moment, we're doing a multi-center analysis from a few sites within the UK. And so we're excited to hopefully report on that in due course.
And what have you seen in the way of complications? What are the safety signals here? Are there any things that we need to be particularly aware of that don't occur with other MIGS procedures? Or is this on the sort of safer, simpler end of that whole MIGS spectrum? Because there's quite a range, isn't there?
I think the beauty with this is that you can do it quite easily through the phaco wound. And because it's simply about the contact with the probe with the trabecular meshwork, doing the procedure is quite straightforward. So within a few cases, I was training up my colleagues to do it and was confident that they were accurately placing those probes as well.
Yeah, certainly for myself, I thought that the learning curve was mainly finding out where the on switch was, and after that, if you're familiar with being in the angle, it was really phenomenally and very reassuringly straightforward. Do you have any sort of experience with the patient perception of laser rather than implant? Are they scared of the word laser, or do they prefer being able to be implant free without a chunk of metal in their eye?
I think, as you know, the word laser, the minute you mention it to the patient, there's always a lot of negative connotations. So I'm a big movie fan, and I always get that Hollywood vibe of Dr. No with the red laser coming at him. So, and it's definitely something that patients perceive and worry about. But once you explain to them that it's a light energy and it's focused specifically to try and open up and get past the diseased trabecular meshwork. So I usually explain to them it's a bit like a drain in a sink becoming clogged with leaves. I'm saying to them that we need to bypass that and try and get flow established to lower the pressure. They're generally quite accepting of having the laser. It doesn't take much more than that to just reassure them.
That's been my experience talking to patients, a lot of patients, about SLT lasers. That I started off using the phrase, focus light energy, and then a couple of patients said, "What, you mean a laser?" But for some people, I think that is the idea of it's just focusing light wavelengths that may be different from normal visible light doesn't really matter, but just focusing light on the tissue. I think they found in some circumstances reassuring. There's one thing while we've got you here, I'd really like to just explore with you. Is there any impact of pigment on this laser? Because, as I said, much as I've done know a lot about SLT, Excimer lasers completely new to me. Not quite a mystery, but completely new to me with this device. And I've never done any refractive surgery other than cataract surgery. Does the pigmentation in the angle have an impact on either the effectiveness of this laser? And then Neeru, you can tell me whether it affects the safety, but Dirk first.
So to understand this, first we need to recognize that SLT and ELT work in very different wavelength ranges. SLT uses visible light, typically green light, 532 nanometers, and for this to get absorbed, pigmentation is very important. It's part of the physical effect that is needed. That's very different for UV light. UV light essentially gets absorbed by any organic material and has a very short absorption depth. So versus, again, visible light penetrating relatively deep into the tissue and only getting absorbed by pigmented substances, UV light gets absorbed in shallow and absorbed by any organic material. And only by these means, and only with UV light, this cold ablation and this cold removal of tissue can be done.
Yes, I think it's interesting. There's an important distinction there, then, isn't there? Because SLT, we don't know how far deep into the eye it penetrates, and if we turn the wick up, it's a very different thing. In fact, we even know that it can come through the sclera now because people have been doing it from outside without the lens. So there may well be much deeper penetration than we realise with SLT. Whereas this, we're back to the story of precision and very, very specific localized tissue effects, which I think is one of the really exciting things about the use of Excimer, obviously for cornea, but also now in the trabecular meshwork. So Neeru, have you had any experience with pigmented and unpigmented angles behaving differently, or can we not worry about that and just treat everyone the same with the Elios laser?
Yeah, so I find it's exactly the same. I don't find that there's any difference given the level of pigment as to whether it's responsive or we see that tissue reaction, bubbles being created during the procedure. I haven't found that there's any difference, which fits with what you've been saying.
And the bubbles are relatively limited, so we're not worrying about damage to endothelium or anything.
They seem to be limited to the site where I've applied the probe, yes.
So not huge streams of bubbles filling the eye that some procedures do.
Yeah, no, that doesn't obstruct your view for the rest of the case. It's just definitely quite localized. It's almost a reassuring sign to see those appear.
So just really slightly self-indulgent because we're meant to be talking about glaucoma, but Dirk, just closing few seconds, can you touch on any other areas within medicine that you're using novel lasers? Are there any other things? Because you're not just an ophthalmology laser person, are you? I think you've got lasers that do other things.
So one other very interesting application of Excimer lasers in medicine actually is laser atherectomy. It uses the same wavelength as for ELT, although with higher powers. It's also fiber coupled going into the arteries to remove plaque, which is a very exciting application just outside of ophthalmology.
Wow, that is exciting. So thank you very much to the both of you. I think that's really covered some of the simpler questions that people have had, but also really drilled down into some of a touch of the physics and the principles behind the precision of the lasers that we're using for the Elios minimally invasive glaucoma surgery. And Neeru, thank you very much indeed for sharing your clinical experience and expertise through the light of your tissue culture and lab work. And Dirk, thank you very much indeed for joining us here on the podcast.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more details on this episode and to read the show notes, visit eliosvision.com/OUS/podcast. To learn more about Elios and contact us, click the link in the description. The Elios system Bausch and Lomb is manufactured by MLase GmbH and by WEINERT Fibre Optics GmbH. Elios is CE marked for use in adult patients with glaucoma and is currently under investigational use in the US as part of an ongoing IDE study by the FDA. The ExTra 2 Laser Class 4 has the brand name Elios. The ExTra 2 is equivalent to ExTra and AIDA devices. Please refer to the full disclaimer in the show notes.